Okay, so today's lecture is about tracheoesophageal fistula. And tracheoesophageal fistula, as the name suggests, is a fistula between the trachea and the esophagus, basically a connection. So usually in the normal anatomy, the trachea is this is the normal anatomy. So this is the trachea in the yellow and esophagus in the white. And this is the normal anatomy where the trachea is anterior, esophagus is posterior, obviously. Now there is a type A and S tracheoesophageal fistula, and this is a pure esophageal atresia. This is called as a pure esophageal atresia. Okay, atresia or stenosis. Well, if it's stenosis, we call it F type. We'll get to that. We'll get to that soon. But A type is pure esophageal atresia. There's nothing in between. So this is the A type. Okay, tracheoesophageal fistula type A. Well, there is no fistula here, but there is an atresia. Type B is when the upper part of the esophagus is connected or is opening into the trachea. Alright, so the proximal connection, that is the tracheoesophageal fistula with the proximal connection, so proximally. Okay. Type C is the most common one, where the distal part of the esophagus opens into the trachea. Alright, so this is the type C, which is the most common one and most commonly seen in the population. Type E, or also I like to call it type H because it makes an H shape, is when the esophagus makes a fistula into the trachea, making an H shape, as you can see here. Alright, so it's called the pure tracheoesophageal fistula. It's called the pure tracheoesophageal fistula. Why? Because the fistula is not just on one end, but the entire esophagus has a fistula. So it's a pure tracheoesophageal fistula. The D is when both the ends are opening into the trachea, but they are not opening together, as in the case of a pure tracheoesophageal fistula or type B of tracheoesophageal fistula. And this is called type D because it enters separately. One opens proximally, the other opens distally. Okay. And then type F is when you have an esophageal atresia. Actually, lesser than atresia, I would say we would write stenosis. Okay, so that could be your type F. Now, what are the causes of a tracheoesophageal fistula? That's been asked, and it is usually associated with NMYC. Now, MYC is a MYC is a pro-oncogene. Okay, so if there is a mutation in the NYC gene, there is going to be tracheoesophageal fistula or anomalies. Okay, what are the symptoms? The symptoms are simple. What happens is that in the fetus, okay, the fetus is going to drink the amniotic fluid. So let me write it well. This is the amniotic fluid. It has to enter the fetus via two routes. One is the nasal and then the lungs, or through the GIT. Now the GIT has a fistula, correct? So the amniotic fluid cannot enter. But it can definitely enter through the lungs, and from the lungs it's absorbed into the blood, and then it's excreted by the kidney and stuff like that. There are other modes also. There can be absorption by skin, but one of the major modes of absorption of the amniotic fluid or ingestion of the amniotic fluid is by the GIT, and GIT is compromised. So obviously you will see certain amount of polyhydramnios in the mother, correct? You will see polyhydramnios. Second is that you would also have respiratory distress because increased substances that enter into the trachea. For instance, this is a trachea, and if there is a fistula like say type B, so a lot of the food is going to enter. Or even in type C, you could have secretions that could enter into the trachea, retrograde secretions. So there's going to be certain amount of respiratory distress. Also, there's going to be I feel there could be also bronchoconstriction because of these responses. Third is there could be dribbling of saliva, and that is usually seen in type C, where if this is the trachea, all right, trachea. This is the esophagus, and this is the lower part of, or the distal esophagus that's opening. So out here there's going to be a pooling of saliva. There's pooling of saliva, and that causes dribbling of saliva. All right. How do you want to diagnose this? How do you want to diagnose this entire condition? The best way is, or the most trusted for confirmation, is your contrast study. You put an iohexol dye, and you can see the contrast easily. If obviously it's going to show that it's entering the trachea or somewhere, so you use an iohexol dye. Other thing that you could use is fundus gas. So what happens is that obviously the esophagus has air, and it enters through the diaphragm into the abdominal cavity and then into the stomach. And when it does that, there could be certain amount of air. All right. But if the, let's say, the fistula is present into the trachea, that means there's increased air. Correct. There's increased air, so therefore there's going to be increased fundus gas, and therefore it is increased in type C and also in type H. Okay, it's increased in type C and in type H. The other method is you do a tracheoesophagoscopy. It's rarely done, but you could do it because it's directly going to show the fistula. Okay. So that being about the tracheoesophageal fistula, a very important point that I wanted to make is that, let's say you see a patient or a kid with tracheoesophageal fistula. Obviously, you will see a infant with tracheoesophageal fistula. So what do you want to check next? You want to make sure that they do not have any vertebral anomalies, vertebrae. So you check for vertebrae. You check for the cleft. You check for the cardiac defect. All right, cardiac defects. You check for anorectal malformations. Let's say there is any congenital lack of anal fistula, or there's a congenital anal fistula, or even the anal opening is not well developed. Any of those cases. You also check for renal agenesis, and you check for limb defects. So the mnemonic comes up as Vactral. Okay. So yes, you do that. Just keep that in mind. It's more of a clinical thing. And let's talk about the management. Okay, the management of this entire condition. But before that, I also want to make a point that when you're doing a nasogastric tube, okay, when you're trying to put a nasogastric tube, let's say you're putting a nasogastric tube, and the nasogastric tube obviously enters from the nasal cavity. All right, it enters it from the nasal cavity and goes into the esophagus, into the stomach. Correct. That's a nasogastric tube. But now the esophagus itself has an atresia. What happens is that there is coiling up of the nasogastric tube. So if this yellow is the nasogastric tube and the green is the esophageal atresia, there's going to be coiling up of the nasogastric tube, and that is also kind of a diagnostic marker that there could be a certain condition. The other thing is that what does the mother complain of? Well, the mother also complains of that every time she feeds, there's a lot of vomiting. And again, that's very basic, because the esophagus does not open in type C, which is the most common. So all of the contents that are present out here in the esophagus, the milk, is obviously going to be vomit. Okay, and therefore the baby does not thrive usually if not treated. Okay, and as I told you, respiratory distress because of the laryngospasm as well could occur, and bronchospasm. Okay, laryngospasm, bronchospasm, and that can lead to cyanosis. So usually what happens is that there is going to be a classical presentation where the patient is going to come to you. She's going to, the infant is going to come, the mother is going to come, and she's going to say that every time I feed the baby does not vomits. Okay, now your DD would come up to usually, the baby. First of all, you would think of a tracheoesophageal fistula, but you would also think of Jamaican vomiting disease. We'll talk about that later someday. And you could think of a lot of conditions where vomiting is there. Then the patient complains that she's also cyanotic. Okay, she's also cyanotic, and you want to check. Then you definitely want to check for your patency of the of the trachea, and that's when we will find out that there is going to be a tracheoesophageal fistula. Now let's talk about the management of the tracheoesophageal fistula. Well, the rule is, there's a simple rule. Okay, if the weight is 2.5 kg, okay, so you have to have a minimum weight of 2.5 kg, minimum. Okay, after that, if it's more, obviously a blessing. So if the minimum weight of 2.5 kg is there, okay, and there is no pneumonia, okay, so you go for surgery. If the weight is 1.5 to 2.5 kgs, okay, and there is pneumonia, okay, so you cannot do the surgery, obviously, because pneumonia can worsen, okay, it can reach the deeper parts of the respiratory tract. So what you do is you give antibiotics, IV, and you give the nutrition. You give a good nutritional support so that you can increase the weight of the baby. Now, once the weight of the baby has increased, okay, you've done that, then you can go for your surgical procedures. Now, the surgical procedures, obviously, for the type of tracheoesophageal fistula is going to be different. So, you do a contrast study and you find out which type of tracheoesophageal fistula is present. Okay. So, if it is a type A, what you do is that, as I told you, in type A, if this is the esophagus, as you've seen in the blue, if this is the esophagus, okay, there is nothing between them. It's a proper atresia. So what you do, or it could be like this, the membranes could be touching. So what you do is that you just cut it, or you just bring it close to each other. So that's when you do a normal anastomosis. Okay, that's a normal anastomosis. If the esophageal atresia is intense, okay, it's quite far apart, it's far apart, as you can see here. So what you do is that you provide for nutrition, okay, wait for them to grow, the esophagus, and then you anastomose. You cannot do that later, because simply because of the normal logical thinking that if you get something, if you pull something, obviously there's a higher chance of tear. Okay, now let's say if there's a B, C, D, H, or E. Okay, so what surgery do? You do a surgery called as Cameron height surgery. All right. And how do you approach this? You approach this by opening the thorax. You have no other option, thoracotomy. But you do a posterior, you go from the posterior aspect, because they say that the posterior lateral aspect is better, okay, for the tracheoesophageal fistula. So obviously here you can see that we are talking about a type C fistula here, the best example, because that's the most common and most commonly seen as well. So what you do is that you first cut the fistula. You've cut the fistula, you repair the fistula out here. Okay, you repair the fistula so that nothing leaks, no air leaks, no mucus secretion leaks into the thoracic cavity. Then you anastomose the esophagus, and then you will have your final normal trachea and esophagus. Now, what is the complication of the surgery? The complication is one and only. Well, the earliest complication is a leak. Let's say this anastomosis breaks for some reason. Okay, you do not have a good anastomosis. Okay, so there's a leak of food into the thorax, which is bad and has to be managed. And the late complication is that because there is anastomosis that is done between the two, as you can see, these narrow strictures could be formed. All right, so stricture formation is seen as a late complication, and that again is a issue. Again might need surgical intervention. Does not definitely need, but might need. Okay, another very important, interesting idea that has come up is something called as a flourish device, and this flourish device is only seen in type A. What they do is that they put a magnet on the two ends of the esophagus, and they allow the two magnets to attract each other, eventually lengthening the entire esophagus, allowing us to do anastomosis. But I think nutrition is also a very good aspect and approach. So that's about it for tracheoesophageal fistula. And as I told you, I showed you the image, and we'll talk about the image a little. So basically, this is your type A that I spoke of, your EA, which is your type A. This is your normal. All right, this is your type A, this is your normal. A gastric bubble is seen in normal. The pure EA will never show a gastric bubble because there's nothing entering. All right, okay. The pure TEF is the H type that I told you, and there's increased gas that's entering, so there'll be a prominent gastric bubble. And this is the most common, that is the type C that I spoke of, and again there'll be an increased gastric bubble because air is going to definitely enter. And that being about it, thank you very much.